रुमाल तो कटिया अंदर चाले आने चाले
Okay. Good morning, friends. Welcome back to Saturday Club of Baroda morning meeting. Today we have Dr. Pankaj Sharma with us. He is a consultant neurologist practicing in Vadodara. He has done his DM in neurology from Jaipur, and he is affiliated to several hospitals in Vadodara. He also has several primary headache disorders to this club.
Satish bhai, your
Thank you
voice.
for joining us. So, voice is not heard. Okay, let me see.
Okay. Now it is audible.
Okay, could you hear the introduction which I gave?
No.
Pankaj, could you hear?
Yes, sir. Yes, sir.
Okay. Maybe Kiran bhai's net may be unstable.
Nahin. Audible.
Okay,
Okay.
audible. So with this brief introduction to Dr. Pankaj Sharma, I request him to start his talk. Pankaj, you have about 45 minutes to talk, and then we'll have question answer later on. And I thank Dr. Kiran bhai for introducing you to our club. And Kiran bhai will conduct the question answer session. I
Yes,
may
sir.
be leaving in between because of the conference which I am attending at Surabhi. So
Yes,
thank
sir.
you all for joining. And over to Pankaj, and then Dr. Kiran Shah will take over the question answer session. Thank you all.
Yes, sir. Thank you, sir. Good morning, all respected teachers and my dear friends. Today we are going to discuss regarding primary headache disorders. So, see, this is the outline that we are going to follow. We are going to discuss regarding pain-sensitive structures in the skull, thereafter followed by classification of headache. We are going to discuss all major three categories of primary headache disorders, that is migraine, tension type headache, as well as trigeminal autonomic cephalgia. We'll also cover a little bit about chronic headache and other primary headache disorders. So, which are the pain sensitive structures in the head? Basically, all the extracranial structures, including the eyes, orbit, sinuses, ear, teeth, TMJ, including the external carotid artery and the branches, these are all pain sensitive. However, intracranially, not all structures are pain sensitive. Brain parenchyma is painless. However, the arteries of circle of Willis as well as the proximal dural vessels, these are pain sensitive. The dural sinuses, including the dura as well as the pia mater, is pain sensitive. The pain from these areas is carried via the efferents, which are basically branches of the 5th, 7th, 9th, as well as 10th cranial nerve, as well as the cervical nerve roots of the upper cervical nerve segments. And they go to the trigeminal nucleus, which is located in the pons. And over there is basically facilitatory as well as inhibitory input, which is basically modulating this pain. And that basically comes from various segments of the brainstem. So that is the periaqueductal gray, rostral ventromedial medulla, locus ceruleus, as well as dorsal raphe nucleus. So over here, the pain is being modulated. So for example, in literal terms, when we are emotional, we'll experience more amount of pain, but when as compared to when we are excited, after a walk or a run, we would experience a little bit less amount of pain. So this is the ICHD-3 classification of headache that we follow right now. Basically, the major category is the primary headache disorders that we are going to discuss today. The second category is the secondary headache, wherein headache would occur as a part of some systemic or other form of illness. And third are the craniofacial neuralgic pains as well as facial pains, including trigeminal neuralgias. So these are the common causes of headache. Most headaches are secondary headaches. So the commonest headaches are secondary headaches, but primary headaches, within primary headaches, tension type headache is way more common as compared to migraine. It is about 69% as compared to migraine frequency, about 15 to 20%. However, as clinicians, we would experience more patients of migraine as compared to tension type headache. The basic reason being tension type headache is a little bit mild to moderate in intensity, and these patients, they would have chronic headaches and they would not come to your outpatient visits. headaches so frequently, and they would take medicines over the counter. That is why in OPD we see more number of patients of migraine as compared to patients with attention type headache. Apart from these two, idiopathic stabbing headache, exertional headache, etc., are very common. Within trigeminal autonomic cephalgia, cluster headache is relatively uncommon. So you can see the frequency of cluster is 0.1% only of all the primary headache disorders. Within secondary headaches also, I would like to emphasize that brain tumor has the frequency of only 0.1%. So tumor is very unlikely to come to you with symptom of headache rather than any other focal neurological deficit on examination. Predominantly it is infection, including fever, viral infections, which would present to us with headache, especially systemic infection. And that is followed by head injuries, vascular disorders, SAH, etc. So various red flags that would suggest a serious underlying disorder when a patient presents to us with headache. So if it is a worst headache noticed by the patient ever, if it is first episode of severe headache, if it is a headache which is subacutely worsening over days to weeks, or with associated abnormal neurological examination, or patient has systemic signs like fever or weight loss or persistent cough, vomiting, pain which is worsened with Valsalvas like bending, lifting, coughing, pain which is disturbing sleep or making patient get up from the sleep, patients who are elderly after 55, any new onset pain, any new onset headache is considered to be red flag, and pain which is associated with localized tenderness again after 55 over the temporal artery for giant cell arteritis. So these basically make us to go for an urgent imaging in such cases to rule out secondary causes as compared to the primary headache. So today's topic is primary headache. So we are going to discuss migraine, tension type headache, and TACs. So migraine, it is a Greek terminology which basically meant hemicranios. So literally meaning half of the head. And that is what is the common conception about migraine. And this is how we classify migraine. So migraine could be episodic or chronic migraine. Episodic migraine could be with aura or without aura. Without aura is called as common migraine, and with aura is called as classical migraine. Aura could be typical aura, could be brainstem aura, could be hemiplegic variant, which is basically a motor aura, or could be a retinal migraine, and it could be a chronic migraine. There are certain complications of migraine, especially status. We all know. We also know persistent aura but without infarction, or could be infarction due to aura, or sometimes aura is followed by seizure. So aura is triggering a episode of seizure. There is again certain syndromes which are associated with migraine, like this recurrent gastrointestinal disturbance, so abdominal pain syndrome, recurrent vomiting syndrome, benign paroxysmal vertigo, and benign paroxysmal torticollis. More commonly seen, these are atypical variants of migraine and commonly seen with pediatric population as compared to adults. So the pathophysiology for migraine, previously, there used to be the vascular theory, which was very prominent for migraine, that there is vasoconstriction, which leads to the aura, and that is followed by vasodilatation that leads to the classical pain, the throbbing nature of the headache. However, this theory is now being put on the back front, and the newer neuronal theory has come up, which basically means that the vascular changes which do occur, however, these are secondary to the neuronal hyperexcitability. So there is a genetic tendency, which is there is a genetic hypersensitivity of the neurons, which basically gets triggered by some external stimulant, and that leads to this vasoconstriction followed by vasodilatation theory. And then there is again cortical spreading depression theory of the aura. So basically we see aura would spread gradually from one part of the body to the other like a focal seizure, and that is why this theory came up of the cortical spreading depression. So this is how it works. So there is pre-symptomatic hyperexcitability in the brainstem, and this basically would respond to triggers, and that would lead to release of various neurotransmitters, which would basically activate the pain-sensitive structures in the trigeminal nucleus, which secondarily activates different areas of the brain. So, for example, there is a dilatation of the meningeal blood vessels, which is going to produce headache because brain parenchyma per se is painless. There would be activation of area postrema in the dorsal medulla that is going to produce nausea as well as vomiting. There would be activation of the cortex and the thalamus that is going to lead to the headache. There would be activation of the hypothalamus. So hypothalamus would be basically causing all forms of hypersensitivity. So pain would be photophobic, phonophobic, osmophobic. So all these thing is due to hypothalamus. Sometimes even thalamus is involved, that would lead to drowsiness, sedation. There would be activation of these cervical trigeminal complex. So that is basically causing this cervical spasm, which is commonly seen with migraine and very commonly misdiagnosed with as cervical radiculopathy. So this is what I am talking about. So there is basically activation of this TCC, that is trigeminocervical complex, and the activation of this trigeminocervical complex will lead to secondary dilatation of the blood vessels. It is going to lead to activation of the hypothalamus, which is going to produce all forms of sensitivities, thalamic production, which is going to cause decrease all the changes of homeostasis. So there would be a lot of polyuria, there would be a lot of polyphagia, there would be altered sleep-wake cycle, there would be activation of the cervical complex that is going to lead to spasm of the cervical muscles and falsely diagnosed as cervical radiculopathy. So when we talk about epidemiology, migraine would affect about as much as 10 to 15% of general population. It is one of the common causes, accounts for about 10 to 20% of all headaches in adults. And 1% of these patients would have chronic migraine. 10% would always have aura, and 30% may or may not have aura. So around 30% would have migraine with aura, and 70% would have common migraine, that is migraine without aura. Usual age of onset is adolescence, late adolescence, and generally by third decade, most of the patients would have experienced at least one attack of migraine, if not so more. And most of the patients, majority of the patient, about 70% of them would have some form of family history positive. So that gives a very important clue to diagnosis, to clinch the diagnosis of migraine. According to WHO, it's one of the most disabling medical condition worldwide. Now, this is very important slide for migraine. So there are various triggers which would basically cause the activation of these trigeminal nucleus, and this is very important. So these triggers include stress, any form of emotional outburst, flickering of lights or flashes of light, hypoglycemia, altered sleep pattern, both sleep deprivation as well as excessive sleep, menstruation, physical exertion, alcohol, smoking, excess amount of caffeine or withdrawal of caffeine after prolonged use, odors, very common. Foods, now from Indian perspective, Chinese foods, all the fermented foods like dhokla, khaman, handwa, Italy, all these can lead to triggering of migraine. Old cheese, which is basically containing tyramines, old paneer, these can trigger migraine. Change in weather can also trigger migraine. Of course, certain drugs can trigger migraine like estrogens, theophylline, nitroglycerin, etc. So this is the common migraine or migraine without aura, also called as hemicrania simplex. Now, basically, patient would have a recurrent headache, which is lasting for about 4 to 72 hours. It would be unilateral, pulsatile in quality of moderate to severe intensity, aggravated by ADLs, as well as associated with nausea or phobia. So this is the diagnostic ICHD-3 diagnostic criteria for migraine, which is simple migraine. At least we need 5 attacks, which is fulfilling criteria B2D. The attacks usually last for about 4 to 72 hours, if not successfully treated. The attacks should have at least 2 of the following. It should be either unilateral, it should be pulsatile or throbbing in nature, moderate to severe in intensity, and aggravated or causing avoidance of routine physical activity. And during headache, at least one of the 2 has to be present, either nausea, vomiting, or photophonophobia. And of course, should never be better accounted from any other diagnosis. So this was migraine without aura, which is common migraine about 70%. In patients with migraine with aura, that is also called as classical migraine or complicated migraine, patient would have recurrent attacks of fully reversible, unilateral, lasting for a couple of minutes, usually more than 5 minutes, but less than 1 hour, 60 minutes, development of a gradual progressive development or a sequential progressive development of a few auras that is succeeded by headache or simultaneously associated with headache and other migrainous symptoms. So the diagnostic criteria for complicated migraine is, you can see the difference. Over there were 5 attacks, but over here we need only 2 attacks. The basic reason being this is relatively malignant. So we need to treat these patients early. So we make the diagnosis early. So we need at least 2 attacks with following fully reversible aura, which includes basically 6 types of aura: visual, sensory, speech and or language, motor, brainstem, and retinal. So in visual, patients would have all forms of scotomas, they would have fortification spectra, they would have glares of lights, etc. In sensory aura, patient might experience hemi-numbness, hemi-paresthesias, involving half of the body, half of the face. In speech and or language aura, basically patient would have difficulty in speech. So they might have dysarthria or they might have aphasia. Sometimes patient comes that preceding to headache, patient is unable to communicate well and is unable to actually use the words which he meant to use, and is supplementing those words with some form of other words. In motor aura, patient might experience weakness, so that is the hemiplegic variant. Brainstem aura, it is a long group of symptoms which may manifest, including tinnitus, including hyperacusis, including neck pain, including vertigo, including diplopia, and sometimes even dysarthria. And in the retinal aura, patient might experience all forms of visual alterations. So any one or more of the fully reversible aura, and at least two of the following four has to be there. So at least one aura has to spread gradually over 5 minutes, or two or more symptoms should occur in succession. And each individual aura symptom should last for about 5 to 60 minutes. It should be unilateral. It's at least one has to be unilateral, and it should be accompanied or followed with headache within next 60 minutes. Of course, not better accounted for. So most common aura is visual aura, which is seen in more than 90% patients of migraine with aura, and it is often presenting as fortification spectra. This what they have seen written over here is the phases of migraine. So basically, migraine has 4 phases, especially those with aura. So there is prodrome. In prodrome, patient would have fatigue, patient would have excessive sleepiness, patient would have difficulty in concentrating, mild photophonophobia, mild neck stiffness, mild vertigo. That would be faced followed with aura, and aura would last for about an hour or two, and then there would be headache. And post headache, patient would again go to post-drome. So post-drome would again be very similar to the prodrome, and that is followed by interictal period. So these are the fortification spectra. Characteristically, we ask patients that you see something like as the name suggests, it is like walls of the forts. So it is something up and down and up and down, and that is associated with brightening and darkness. So bright scotomas, dark scotomas, etc. As far as migraine in women is considered, it is of course much more common as compared to men, as we see in the clinics. It is basically due to hormonal imbalances, especially estrogen withdrawal, which occurs in the premenstrual period. Migraine, which is associated with menstruation, is basically classified into 2 categories. One is the pure menstrual migraine. So in this, patient would exclusively have migraine attacks prior or during the menses, or just succeeding the menses. So day -2 to day +3 of the menstruation cycle. And these patients would be headache free for the rest of the cycle. But then there is something called as a menstruation related migraine, in which the patient would have a headache throughout the cycle, but which would accentuate during the perimenstrual period, and that is much more common as compared to pure menstrual migraine. The importance of identifying this is such patients in pure menstrual migraine, they do not need chronic therapies for prevention of migraine. They need cyclical forms of therapy for prevention of migraine, which is associated with this menstrual cycle. A couple of things about childhood migraine. Again, childhood migraine is one of the most common causes of headache in children. The prevalence is around 5% for the children. But migraine in children is very atypical. It is of shorter duration. It is less unilateral. It is more commonly holocranial, and it is always commonly, rather I would say, associated with atypical migraine syndromes like cyclical vomiting syndrome, or abdominal pain, cyclical abdominal pain, or benign paroxysmal vertigo, benign paroxysmal torticollis, or sometimes alternating hemiplegia of childhood. So these are atypical variants which are commonly seen with again, but family is still very, very, very strong point to clinch the diagnosis. Regarding pharmacological treatment, generally we prefer giving plain paracetamol, acetaminophen in such patients. And for preventive therapy, we may use propranolol and antidepressants, tricyclic antidepressants, amitriptyline for pediatric migraine. But again, to be used only once non-pharmacological managements have been utilized well, and still patient is having pain. So severity of migraine is classified as mild, moderate, severe, and status. So mild patient would be aware of the headache but would be fully functional. In moderate, patient would have difficulty in performing ADL with headache, but in severe, patient would become completely incapacitated and would not be able to function well. In status, the patient headache would last continuously for about 72 hours, more than 72 hours. So as far as management is considered, there is something called as a MIDAS scale, that is Migraine Disability Assessment Score. MIDAS scale is not so commonly used in clinical purposes. It is mainly used for the research purposes. This is the MIDAS questionnaire that we have. Basically, what we are trying to assess is in the past 3 months, how many attacks or how many days of disability patient experienced in both his workplace as well as home, and how much functionally incapacitated was the patient due to headache. That is what we try to assess with this questionnaire, and then we classify the patient according to this. But in the clinics, we basically use this scale, mild, moderate, and severe, and that helps us to titrate the management protocols. And then they're very important in management of migraine is the non-pharmacological management. So we have to avoid, and first we have to identify and then consciously avoid the known triggers. So the way we do that is by maintaining a headache diary. We ask the patient to notify by himself what trigger does he feel which caused the episode of that particular episode of migraine, and then wait for the next attack, and then again note down all the points which probably caused migraine, and then over next 5, 6, 7 attacks, once patient starts writing down multiple possible triggers, they will start seeing a pattern that something probably of the listed possible triggers is causing headache, which is happening all the time prior to headache. So these are basically the main triggers, and these triggers would vary from person to person. So within a family also the trigger would vary. So we need to be very personal in this. So personalized precision approach basically is the headache diary in such cases. Apart from this, a healthful diet, regular exercise, regular sleep patterns, avoidance of excessive caffeine and alcohol, and acute changes in stress level. So meditation, yoga, etc. would help. Then therapies for acute attack of migraine. So in simple analgesics, NSAIDs, dopamine antagonist, basically for the antiemetic effects, and certain other drugs, basically triptans, detans, and gepants, basically used for management of acute attack of migraine. So and simple analgesics basically used for mild to moderate category of migraine, especially when the patient is able to tolerate well orally. This includes simple plain paracetamol 1 gram or aspirin 900 milligram. Or NSAIDs, including very commonly used naproxen, or even ibuprofen can be used in such cases. Now, when it comes to the specific therapies, the triptans, which are the drugs which have been used since many years, these are very good efficacious molecules. They are basically serotonin 1B, 1D, 1F receptor agonist. But because of this, they have two effects. So because of 1B, 1D, they causes vasoconstriction, and because of 1F, they also causes inhibition of release of CGRP and substance P. Those are the pro-inflammatory cytokines responsible for headache. These are generally well tolerated, but the only point to be remembered is in patients with vascular disorders, especially ischemic heart disease, history of angina or myocardial infarction or uncontrolled hypertension, these should be not given, better avoided. Similar molecules are the ergot alkaloids. Again, these are 1B, 1D receptor agonists. But the issue with them again is one, very important, ischemia, and second is rebound headache, and third, very, very important clinically, which is visible, is nausea and vomiting. So these are the molecules which are not so much used. They are basically superseded with the triptans. But again, same thing, never to be combined with triptans because very high risk of vascular disease, especially ischemic heart disease. So these are the newer alternatives which have come up. So we have the detans as well as the gepants. Detans are basically 5-HT1F receptor, selective 1F receptor agonist, and because they don't have any action on 1D and 1F, 1B and 1D, they don't act on the vascular system. So therefore, they will only act on the trigeminal system, and thereby decreasing the inflammation and therefore decreasing the headache. The molecule that we now very commonly use in clinics are the lasmiditan. The 2-hour pain-free period is about 40%, and we generally begin with 50 mg HS, and then we escalate if required to 100 and 200 mg. But the very important pointers to be remembered should be given only at night, but driving should be avoided because sedation is a very important side effect that is noted with this. Second thing, never to be repeated in 24 hours, and only up to 4 doses per month to be given. And this is only for a specific group of patients. So patients who have inadequate response to plain analgesics as well as combination of analgesics and triptans. So after failure of triptans, in the refractory cases, we use detans. This is available in India. We also have gepants, that is a CGRP receptor agonist, that is ubrogepant and rimegepant. Again, these are for refractory cases only. The side effect profile is relatively safe, but the issue with them is they are very costly drugs. So the cost is around 1,000 per tablet. And again, ubrogepant can be repeated after 24 hours, but rimegepant cannot. We have certain other things which are non-pharmacological management when it comes to migraine. So these are basically the neuromodulation. So basically we are modulating the efferent pain pathway as well, and thereby modulating the efferents to the trigeminal nucleus. These includes the external trigeminal nerve stimulator as well as the single pulse transcranial magnetic stimulator. What we commonly use in India is the remote electrical neuromodulation devices. Again, cost is an issue. Otherwise, these are also better options, and the efficacy is at par as compared to the drugs. And because these are non-pharmacological, some patients would opt voluntarily for them. And in cases of refractory cases, this could also be combined. They would reduce the dose of the pharmacological management. Then comes to migraine prophylaxis. So in which patients we need to give migraine prophylaxis? These are the indications if the patient is having more than 2 attacks per week, or if the patient is having prolonged attacks of lasting for more than 48 hours. If patient is having severe migraine, even a single attack would make the patient eligible for migraine prophylaxis. Regular predicted attacks, as we discussed previously, menstrual migraine. So we will give cyclical prophylaxis to these drugs, to these patients with, and some tricyclic antidepressants. Patient preferences. Sometimes, young patients who are in a high working professional, they don't want this recurrent attacks of episodic migraine also. So in that case also, you may prescribe them migraine prophylaxis if side effects are well discussed with the patient. And of course, all forms of malignant migraine, all forms of migraine with aura. So hemiplegic basilar migraine, migraine with prolonged aura, and migrainous infarction. They need to be always given prophylaxis even after first episode. So these are the drugs which we commonly use for preventive therapies in migraine. These includes beta blockers, very commonly used propranolol. Tricyclic antidepressants, we use amitriptyline, dotiapine, as well as tricyclic nortriptyline. We also have calcium channel blockers like flunarizine, very commonly used. Issue with beta blocker is basically tiredness, postural symptoms, especially in elderly, contraindications in asthma. Sometimes patient would have vivid night dreams. So that those are the issue. Erectile dysfunction is again an issue with propranolol. With tricyclic antidepressant, drowsiness is a major issue. Apart from that, all forms of anticholinergic side effects are very common, especially in elderly. It is a little bit troublesome, but again, nortriptyline would be relatively better as compared to amitriptyline in adults. And as compared to flunarizine, the major side effect with flunarizine is weight gain and a little bit of depression. Flunarizine, again, a very important point, should not be given in patients with Parkinsonism because it may cause Parkinsonism, drug-induced Parkinsonism. Regarding anticonvulsant, these are generally considered as second line after failure of first line. A failure of combination of first line therapies is unable to prevent migraine, or we have some form of contraindication to the first line therapies, we would go for second line therapies. Second line therapies would include anticonvulsants like topiramate, valproate, gabapentin. Topiramate, very good thing about that is it causes weight loss, but then a very important word of caution should be used, should be carefully selected, used in selected group of patients. Glaucoma should be ruled out, and renal stone should be ruled out. With valproic acid, again, all forms of side effects like drowsiness, weight gain, tremor, hair loss, and fetal abnormalities is there. Gabapentin can be used, but it is relatively less efficacious. See, no convincing evidence from trials for verapamil exists, but in practical world, verapamil does help because verapamil is commonly given for cluster, and many patients with cluster migraine duo, we prefer giving verapamil, and that helps with the treatment of both. So this is how first line therapy works. We give one of the drug based upon the side effect profile and the need of the patients, and we always screen these patients for depression and anxiety because comorbid depression and anxiety is very common. Patient education and lifestyle management of headache, diarrhea, identification of trigger, and conscious avoidance of those triggers has to be done. And in second line treatment, we may use combinations and different molecules, and anticonvulsants can be used. Now we talk about tension type headache. So again, this is the most common form of primary headache, and it is almost twice or thrice as common as migraine, but most of the patients, they don't come to the clinic. So the patient would experience a bilateral tight band-like discomfort. So this is usually a working class male or a female who would experience heaviness in the head, which is holocranial, and it would the patient would say that he experienced this most in the later half of the days. So that is how it works. So during the evening or the night time, after he gets back from the hospital, gets back from his workplace, he would experience these sensations, and the patient would say that he feels better by applying a tight band around his head. So in India, we have very common practice of applying dupatta over the head, and the patient would feel better. Usually we are dealing with tension type headache. And a very important note, the patient, if you touch the scalp, the patient might have the radial tenderness. Such patients might have, even in the interictal period, they might have this. So the patient's headache would build very slowly, it would fluctuate, and it would persist for more or less continuously for many days. It could be, again, TTH could be episodic as well as chronic. And the typical tenderness would be increased during the actual headache episodes. So when we talk about infrequent episodic tension type headache, the pain would be typically bilateral, pressing or tightening in quality, and mild to moderate in intensity, which is lasting for minutes to up to days. So up to 7 days it would last. But however, patient does not worsen with routine physical activity, and that is why they don't present to the clinic, and not associated with photophobia. Sorry, not associated with nausea, vomiting, but may or may not be associated with either of the photo or phonophobia. And so this is the diagnostic criteria for infrequent form of tension type headache. For infrequent form of tension type headache, the number of episodes are less than 1 episode per month. So less than 1 day per month. And if there are 10 such episodes, which is lasting for 30 to 70 minutes, which should have at least 2 of the following 4. So it should be bilateral, that is holocranial, pressing or tightening, that is non-pulsatile in quality, mild to moderate in intensity. Note that migraine was moderate to severe in intensity and not aggravated by routine physical activity. And both of the following, that is, there should be no nausea, vomiting, but photo or phonophobia, either of the two can be present. So when we talk about the frequent episodic tension type headache, note it is episodic, it is not chronic, it is episodic, but it is frequent. So frequent would mean that the attacks would last for about 1 to 14 days, up to 14 days per month, on an average for 3 months. And the rest of the criteria is same. The duration is same, 30 to 7 minutes, and with at least 2 of the following and either one of the following. And then we talk about how do we manage these patients of tension type headache. So again, for the management of tension type headache, simple plain analgesics such as paracetamol, aspirin, or any other NSAIDs like naproxen or ibupera would work well. Behavioral approach is very important for management of tension type headache, because these headaches are mild to moderate in intensity. So basic relaxation exercises, meditation, yoga, pranayam can help in such patients. Avoidance, conscious avoidance of stress, conscious avoidance of overexertion can prevent these infrequent attacks of headache. And maintaining proper sleep cycle, drinking plenty of oral fluids, and having regular meals would also prevent these. But the problem with tension type headache is a very high risk of rebound headache. So you don't generally give them chronic forms of treatment. So you generally give a short cycle of NSAID or a PCM, and then you will stop it, because if you give for a chronic period, very good chances that these patients will develop rebound headaches. As far as preventive treatment is considered, again, that would be given only in patients with chronic form of tension type headache. Chronic form basically includes patients with more than 15 days of headache per month for at least 3 months. And again, as I said previously, non-pharmacological management, including proper sleep cycle, stress management, acupuncture, biofeedback, and physical therapy, and pharmacological management in the form of tricyclic antidepressant. Amitriptyline works very good in such patients. The third category of the third category of primary headache disorders that we are going to discuss is the trigeminal autonomic cephalgias. As the name suggests, this is in the trigeminal distribution. The headache would occur in trigeminal distribution. Autonomic. So these patients would have certain autonomic symptoms. So these are parasympathetic as well as sympathetic autonomic symptoms. And then these would include headaches like cluster headache, paroxysmal hemicrania, Sankt as well as Suna, and hemicrania continua. So these would be having a relatively shorter lasting as compared to migraine and TTH. The headache would be relatively short lasting, and they would be associated with these cranial autonomic symptoms. So what is the pathophysiology? Again, there is activation of the trigeminal nerve pathway, as well as there is activation of the parasympathetic pathway. So there is increase in parasympathetic outflow, which will cause all forms of dysautonomic symptoms. So there would be forehead and facial flushing, there would be lacrimation, there would be conjunctival injection, there would be nasal stuffiness, there would be rhinorrhea, eyelid edema, etc. And along with that, what happens is the carotid canal, it basically, there is perivascular edema, inflammation and edema of the carotid canal. So over there, your post-ganglionic sympathetic plexus lies. So that gets compressed. And because of that, secondarily, there would be sympathetic dysfunction, which is going to produce this Horner's syndrome, that is meiosis as well as ptosis, partial Horner's. So this is how cluster headache works. Very important diagnosis, very commonly missed diagnosis. Cluster headache, it is considered to be one of the worst headaches, worst form of nature of pain. So generally they say that it is even bad as compared to the partum pain. And such patients would, this is also called as suicidal headache. So the patients are very much, the headache is so severe, the patients are prone to take suicidal ideations. So how do we diagnose cluster headache? So as the name suggests, a cluster. So what does cluster mean? Cluster means there is clustering of the headaches. So there would be seasonal clustering of the symptoms. So some patients would have episodes during spring, some patients would have episodes during summer, some patients might have episodes during winter. So in few couple of months, so select couple of months, so for example September to November or whatever, so that would vary from patient to patient, but there would be clustering. So characteristic clustering of symptoms, that is yearly, annually, as well as there would be diurnal clustering of the symptoms. So most of the patient experiences headache midnight. So they would say that when they go to sleep, they were absolutely well, but midnight they experience sudden severe headache, acute severe headache. And every day, every night, rather, they would experience that headache during that particular time of the day. They might, some patients might experience headache during the afternoon. So, there will be again clustering of the symptoms. So this is how you diagnose. And of course, we need all these criteria to be fulfilled. So we need at least 5 attacks of severe to very severe unilateral, orbital, supraorbital, and or temporal pain, which is lasting for short lasting. So even if untreated, they would not last for more than 180 hours. Usually they last for about an hour or two. So 15 minutes to 180 minutes with either of the two. Very important is a sense of restlessness and agitation. The relative with the patient would complain that he becomes very restless and he becomes very much agitated, would not listen to you. And sometimes they would start banging their head on the wall. They would become so restless. And then at least one of the following, that is conjunctival injection lacrimation, nasal congestion and rhinorrhea, eyelid edema, forehead facial flushing or sweating, fullness of ear, as well as meiosis and ptosis. So all the parasympathetic and sympathetic dysfunctional systems. And the frequency would be 1 on every alternate day to 8 per day. So that is how the clusters would occur. And it is of course not better accounted for. And the very important to make the diagnosis accurate, because such form of headache will not be treated with your chronic with your common medicines for both migraine as well as tension type. They would not respond, not responsive. So for management of acute attack of cluster headache, oxygen therapy, it is both therapeutic as well as diagnostic. It is so diagnostic that many a time it is used as a simple diagnostic tool. When a patient is having headache, give him 100% oxygen with a non-rebreather mask at a very high rate of 10 to 15 liter per minute in a tripod position, and that to about for 15 to 20 minutes. There would be a dramatic resolution of headache in such cases if it would be a classic cluster. Other therapies include sumatriptan. So sumatriptan would reduce very rapid in onset, so reduce the frequency duration of the attack to 10 to 15 minutes only. Both in intranasal as well as subcutaneous sumatriptan can be given. Now for the preventive management of cluster headache, there is something called as bridge therapy, and then there is of course prevention of the chronic cluster headaches. So in episodic cluster headache, we generally bridge with prednisolone. So 1 milligram per kg for up to 6 milligram per 6 milligram, and then we taper it gradually over the next 3 weeks slowly. And we also simultaneously treat with drugs like verapamil. Again, very dramatic response. So patient, even with single day therapy of verapamil, patient might experience complete resolution of these cluster episodes and would start sleeping well. Usual dosing is about 160 to 960, but again, a couple of pointers to be remembered. Always take ECG prior to initiation of verapamil to rule out primary AV block, and always take monitor the patient during always gradual taper, and monitor the patient for any sinus bradycardia or AV block. Other therapies include topiramate, gabapentin, melatonin. Melatonin is a good alternative. Neurostimulation therapy as well as occipital nerve block can also be given in such cases. However, they are less efficacious. Then the second form of trigeminal autonomic cephalgia is the paroxysmal hemicrania. So as the name suggests, it is paroxysmal, so it is relatively short lasting and comes and goes, and hemicrania means involves half of the face. So the attacks are more, so there is at least 20 attacks required. Again, same severe unilateral, orbital, supraorbital, and not temporal pain, but the duration is less. You see, only 2 to 30 minutes. If you remember, cluster was 15 to 180 minutes, and at least one of the all the autonomic symptoms, and the frequency is about 5 per day, or for more than half of the duration of the episode. So that is why paroxysmal. And very interestingly, indomethacin is a diagnostic in such cases. So this would be prevented absolutely by therapeutic dose of indomethacin. Indomethacin, as compared to rest all other NSAIDs, has a better CNS penetrability and has certain other mechanism of action apart from the COX inhibition. So they also inhibit nitric oxide release, CGRP release. So that's why they are relatively better responsive, these patients. Then there is always, with paroxysmal hemicrania, always secondary causes needs to be ruled out, because lesions of sella turcica, which includes AVM, meningiomas, or epidermoid can present as paroxysmal hemicrania, especially suspected in patients who require higher dose of indomethacin. Normally, paroxysmal hemicrania would respond to lower doses of indomethacin, less than 100. But if we need at least more than 200, yes, we should suspect secondary paroxysmal hemicrania. As a rule, generally, we consider MRI in all cases of paroxysmal hemicrania to rule out secondary causes, intracranial lesions. Can coexist with trigeminal neuralgia. Indomethacin is drug of choice. Other alternatives include topiramate as well as paroxycan. Then there is Santen Suna. So basically, short, as the name suggests, short-lasting unilateral neuralgiform headache with conjunctival injection and tearing, and short-lasting unilateral headache, neuralgiform headache with dysautonomia, so autonomic manifestations. Again, these are even shorter lasting as compared to paroxysmal hemicrania. So we need at least 20 attacks. Again, moderate to severe unilateral head pain with all the same distribution, lasting for 1 to 60 seconds. So the attacks would last for less than 10 minutes, and they would come as single stab or series of stab or in a sawtooth pattern. So these are very common differential diagnosis for trigeminal neuralgia. So the clinical presentation might be same, but these would be relatively severe, relatively abrupt onset, and they would be often associated with autonomic dysautonomia symptoms. So that is how you differentiate between trigeminal neuralgia and Santen Suna. So the attack frequency would be at least 1 per day for more than half of the period. And again, all patients of Santen Suna, secondary causes needs to be ruled out, because posterior lesions are very commonly associated in such patients. So brain MRI has to be done. The difference between SUNCT and SUNA: in SUNCT, we need both conjunctival injection as well as tearing, that is lacrimation. As the name suggests, in SUNA, we can have either of the two or none of them with other symptoms, other all autonomic, dysautonomic symptoms. So treatment, abortive therapy. Generally, patient doesn't present to us with SUNCT and SUNA headache because the attacks are very short lasting. But if at all it presents, we can give IV lidocaine. Generally, we use only the preventive therapy in such cases because that's how the patient presents. Topiramate, GABA, and carbamazepine are good alternatives. Lamotrigine can also be used. Surgical approaches, if if the medical management is refractory, surgical approaches like microvascular decompression and occipital nerve blocks can also be given. Then the last trigeminal autonomic cephalgia is the hemicrania continua. So as the name suggests, it is continuous. So the continuous pain, which is relatively longer lasting. And again, as because it is a TAC, it involves the half of the face only. So, but very important is side lock. So this is strictly unilateral. The patient would say, so in cluster, the patient might have during one cluster episodes of headache on the right side, and the next attack might have episodes of headache on the left side. But in hemicrania continua, usually the patient would say, I always have attacks on the one side of the face, always. So this is strictly unilateral. Again, all the dysautonomic symptoms, and absolutely sensitive to indomethacin. So generally, many a times when there is a diagnostic dilemma, indomethacin can also be used as a diagnostic tool, therapeutic trial of single tablet of indomethacin. If the patient recovers well, it might be hemicrania. Especially, it is very common differential for cluster headache. But other NSAIDs would be little, or the difference between this and cluster headache is it is relatively chronic. So it would be present for more than 3 months with exacerbations in between. And it is again unilateral, associated with all forms of dysautonomic symptoms, and it is also simultaneously associated with restlessness and agitation, as which was seen with cluster headache. But cluster headache patients will not respond to indomethacin, and hemicrania continua would respond very well. So these are the differential diagnosis of primary headache. So as we discussed, migraine, cluster, and tension type headache. Very important, family history is positive in migraine as well as TTH, may not be positive in cluster. Females are more commonly affected in migraine as well as tension type headache, but cluster characteristically males are more commonly involved. The onset cluster is usually after sleep. Rest onset could be variable. Location, as we have discussed already, the migrainous headache would have throbbing or pulsatile nature. Cluster headache would be sharp, excruciating, steady, but severe, very severe pain. Tension type headache would be dull and featureless, otherwise featureless. And all the different associated symptoms as we have already discussed. So this is the differential diagnosis for trigeminal autonomic cephalgia. So as we have already discussed, cluster paroxysmal. So Botox.
શીખવા મળે બરાબર જુઓ તમે 5 મિનિટ લેવાનું જોઈ લો.
Botox therapy can be given in refractory cases of headache, but the efficacy is almost similar to the pharmacological management. These are the various points where we inject Botox in such patients. These are commonly used as an adjuvant to the pharmacological management in refractory cases of headache. Last slide, couple of pointers regarding other primary headache disorders. So other primary headache includes primary cough headache. So these patients would have exclusive headache only after coughing, and such patients they are very well responsive to the NSAIDs. However, what we need to treat is we need to treat the primary cause of cough in such patients. Then there is something called as primary stabbing headache. These patients would have series of stab-like headache. This is very common form of primary headache disorder, relatively common form of primary headache disorder. Again, very common differential diagnosis for trigeminal neuralgia. They would have a stabbing form of a headache, but the treatment is same. So carbamazepine, which works well for trigeminal neuralgia, works well for primary stabbing headache also. Primary exertional headache, patient would experience headache after bouts of exertion. So after coming from a walk or from a jog, especially over exertion, these patients would exclusively headache only and only then. The rest of the time, the patient would be better. So generally, we recommend such patients to exercise in a relatively less humid and relatively less hot environment, stay better hydrated, decrease the intensity of exercise, and may consider taking NSAIDs just prior to the onset of exercise. Then there is primary sex headache. So the patients would experience sudden sharp headache, moderate to very severe in intensity, and the headache would the headache would increase with the sexual act and would peak at the orgasm or just prior to the orgasm. But always more common in seen with males as compared to females, but always first attack has to be considered as a red flag. And the very important differential that needs to be ruled out is subarachnoid hemorrhage. Second differential is the RCVS, reversible cerebral vasoconstriction syndrome. So that needs to be very importantly ruled out before diagnosing as primary sexual headache. Next is again for primary sexual headache, the treatment is we ask the patient, the excitement level has to be reduced. We can give propranolol as well as flunarizine in such patients. That works well. Thunderclap headache. The patient would have sudden onset, very severe headache like subarachnoid hemorrhage, but there would be no bleed. And again, these patients would have recurrent episodes of such headache. These are always considered red flags, and most of the time, repeat imaging has to be done to rule out sentinel bleeds in such patients, because very common differential diagnosis is sentinel bleeds. Sometimes we need even to go for CSF in such patients to rule out presence of xanthochromia and any sentinel bleed as a part of SAH. Sometimes angiogram is also done to rule out aneurysms. And hypnic headache. Hypnic headaches are classically the patient would experience headache at night, at midnight, after some time of sleep, and or early in the morning when they wake up. The headache is predominantly posterior parieto-occipital, and it is moderate to severe in intensity. Very commonly differentiated from cluster headache, but would not have all the symptoms of cranial dysautonomia as we see with cluster headache, and it is relatively less severe as compared to cluster headache. So these are all the primary headache disorders, and of course, all forms of secondary headache disorders are also there, but out of scope of our today's discussion. Thank you.
So, Dr. Pankaj, you are requested to stop sharing your screen so that any question we will take up.
Yes, sir. Then, sir.
Pankaj, I'm Dr. Tushar Choksi,
Yes, sir.
anesthesiologist, right?
Yes,
Now,
sir.
I want to ask you two questions.
Yes, sir.
In our practice, there are very common spinal headache, which is excruciating after spinal given for at
Yes.
least after 24 hours.
Yes, sir.
Now, in this matter,
Yes,
we
sir.
know all the treatment, how to give NSAIDs and hydrotherapies and everything. But
Yes, sir.
sometimes it becomes so worse that we have to put a epidural blood patch, which is
Bilkul.
very, very common nowadays.
Yes,
But
sir.
we use a very short bevel needle with 25. Still, patient gets the spinal headache. But I
Yes,
want to
sir.
know that do you have any recommendation in
Sir, this is the headache that you are talking about is post-dural puncture headache, PDPH. So for post-dural puncture headache, general recommendations, sir, this is more common in young patients, especially those with history of migraine. So PDPH. So we can screen these patients. Second, prior to spinal giving spinal, we can hydrate the patient well. So that way, if we would reduce the possibility of post-dural low CSF pressure. Also, as you rightly mentioned, we can use smaller needles. So 25G or smaller needles can be used in such patients. We can go for the tapping procedure can be guarded. So slow tapping or gradual withdrawal of the CSF while puncturing the needle can be done. It's also even while giving epidural injections. And after post-op, we may also, sir, caffeine has very good role in such cases. So I think combination of caffeine with paracetamol and other forms of analgesics are used. Postural, as you said, head low position, maintaining head low for about 12 to 24 hours. If it is possible from a surgical side, it is always preferred. We generally, in our practice, we generally ask these patients to be given pure dark coffee, sir. Dark coffee works wonders in such patients. So if we administer dark coffee every 6 hourly, patient's headache would decrease dramatically. But some patients, I would say about 1 to 5% patients would experience prolonged PDPH headaches for lasting for up to 5 to 7 days. But generally, it works well with reassurance only. So, sir, we only reassure these patients that this is nothing to be worried. In cases in which the fistula is developing, in those cases with persistent headache, we may need to give epidural blood patch.
One more question, Pankaj, from
one question, Kiran.
Yes,
yes, yes.
Pankaj, what is your is it required that hydrotherapy in all type of the headaches is helpful?
Hydrotherapy means excess amount of water,
taking more water intake.
No, sir. No, sir. Adding optimal water works well. Excess amount of water doesn't work well for all patients, especially would not work well for patients who have raised ICP. So patients with increased CSF pressures due to either primary brain parenchymal insult, in patients with meningitis encephalitis, as well as in patients with the IIH, idiopathic intracranial hypertension. We don't advise this amount of water.
So it is misleading in the spinal headache that we should give them more.
Sir, in spinal headache it will work well. No, sir. In spinal headache it will work well. In post-dural puncture headache, the issue is that there is CSF leak. Iatrogenic CSF leak, which is very well documented. So because there is iatrogenic CSF leak, we give overzealous amount of water to increase the production of CSF, sir. So thereby we try to maintain the CSF pressure. Caffeine also works in the similar fashion. Caffeine will increase the blood pressure. So by increasing the blood pressure, it will increase the production of CSF, sir. So that is how we are trying to maintain the ICP, sir, transiently until that fistula, which was created iatrogenically, gets closed.
So one more question from Dr. Manoj Yadav. Pankaj, how common is gastric headache and where does it come in differential diagnosis of other causes of headache, most commonly migraine headache?
Sir, I think he's talking about abdominal pain syndrome.
Gastric headache and where does it come in differential diagnosis of other causes of headache? Most commonly migraine headache. That is what he wants to ask.
Sir, if I have got the question right,
any specification, Dr. Manoj Yadav, from your side? Okay. So how the gastric headache is to be differentiated with migraine? That is what I can understand from this.
Sir, I am not much aware about gastric headache, per se the term gastric headache. Generally,
Pankaj, what happens, gastric headache means sometimes the gaseous distension, because of the gastric disturbances, patient gets the headache. It's a secondary symptoms because of some psychological setback. That is what he tells.
Sir, sometimes it is the other way around, and I would rather say most of the time it is the other way around. The headache is causing gastric symptoms, which is falsely interpreted as gastric distension causing headache, sir. So most of the time, what happens is migraine patients would have difficulty in normal peristalsis, sir. So that is why that they would have delayed gastric emptying, which might cause over distension of the stomach, and which might be confused as that causing secondary headache rather than primary headache disorder which is presenting as migraine. On similar lines, sir, these patients we have discussed today that such patients, some pediatric patients very commonly would present with gastric pain syndrome, sir. So they would not present with anything, sir, only cyclic and pain syndrome. Every 21-day patient would present to some doctor with abdominal pain. Doctor would undergo all forms of tests, USG, CT scan, everything will come normal, and they will go from one doctor to the next doctor to the next doctor, but the pain would be excruciating, and patient would very well respond to chronic therapies of migraine, including even amitriptyline. Amitriptyline per se causes constipation, but such patients would respond very well to even amitriptyline, that their pain would go away. So especially with pediatric and young adolescent age group, such differential should be kept in mind, and screening for migraine should be done. And very important clue to clinch these diagnoses is the family history. If family history of migraine is there, always should be considered that this could be a cyclical vomiting syndrome or a cyclical abdominal pain syndrome in pediatric age group.
So we call
One
this
patient.
patient every day phantom type psychological headache.
Yes, sir.
Yeah.
One more question, Pankaj, how long the migraine prophylaxis to be given, or is there any criteria wherein we can stop the migraine prophylaxis?
So, sir, there is no criteria up to how long can be given, but in practice, what we do is we escalate. We begin the therapy. Generally, what we do is for first 3 months we will gradually step up the therapy so as to reduce the number of triggers, a number of episodic migraine attacks to less than 4 per month. So once we have achieved somewhat around less than 4 per month, 1 to 2 attacks per month, we would ask the patient to consciously identify the trigger and consciously start avoiding the trigger. So first 3 months, we generally ask the patient to maintain a strong headache diary and to consciously identify the trigger. Once patients avoid the trigger, identify the trigger, they will come to us with the headache diary. We will discuss regarding what are the possible triggers. Most of the patients in India, we have a culture of fasting. So fasting causing headache. So if patient stops fasting, headache will go away. But the issue is if the patient starts fasting again in next Shravan, headache will come back. So, but in the majority of patients, patients start identifying the cause. Once they identify the cause, we gradually start reducing the therapy. So usually the course of therapy is around 6 to 9 months, which includes first 3 months of step up, then 3 months of maintenance, and then 2 to 3 months of down titrating the drugs. And we do it very slowly. At the same time, we utilize each and every episode to educate the patient regarding the triggers and how to consciously identify the trigger and consciously. Second very important thing is to take the medicine at a proper time. So NSAID should be NSAID or sumatriptan should be taken just prior to the headache onset or at the headache onset itself, to be avoided at taking at peak, because at peak if they take, the peristalsis is slow. So if they are taking oral drugs, the effect would come very much late. And migraine per se is like a vicious cycle. So one attack of migraine will increase the intensity, will increase the duration and decrease the inter-attack duration. So increase the frequency of the next further attack. So this is how it works. So if we start reducing this by taking drug in the prodromal or the aura phase, that attack will not come, and that thereby the next attack in succession will also not come. So thereby the cycle will gradually start reducing, but usually it is 6 to 9 months.
Okay. So I think there is any
Well,
question.
second, I think one remark. Pankaj, there are so many. History is very important in taking the headache patient, because hunger's headache, hypoxic headache, hypoglycemic headaches are very, very
Yes, sir.
common in our
Yes,
practice
sir.
sometimes.
Yes, sir.
So we have to be careful in that part. Okay? You should not start immediately the treatment of NSAIDs and everything. We have to
Yes,
ask
sir.
the proper history for that type of the patient.
Absolutely, sir. Totally agreed, sir. Because it is going to be very bad if we overdiagnose migraine and we rule out, we miss secondary causes of headache. That would be detrimental to the patient. So migraine diagnosis should only be made clinically if the headache is very chronic, family history is strong positive, and the headache is fulfilling all criteria for migraine. It should be very well remembered that secondary headache can present with all characteristics of migraine, but with a relatively acute onset. And second thing, we in such patients we always ask, is the headache similar to what he or she experienced prior? If the headache is of different nature, that is also a very important red flag to consider such patients for secondary, screen these patients for secondary cause of headache, sir.
So thank you, Pankaj, for giving us a very good insight about this particular topic of headache. Though it is very difficult to diagnose the headache, and it is the most probably the patients which we are facing in day-to-day life, I think. But anyway, you had given us a very good insight, particularly in this primary headache topic. I think.
Yes.
Thank you.
Thank you,
for
sir.
having a wonderful. So we'll stop here. Okay.
Thank you, sir.
So there is a congratulations for you from Dr. Satish Bhai and very
Yes, sir.
okay.
Thank you, sir.
Thank you.